ফিরোজ শুরু করবা?
স্যার ওরা বলবে স্যার।
Yes, sir, you can start.
Okay. Good evening, ladies and gentlemen. Welcome you all to this webinar on ECG Basic and Beyond. This is the 23rd lecture of this webinar. Today we'll discuss some case studies on ECG. We have got our course director, Professor Atahar Ali sir and Professor Abdul Wadud Chowdhury sir with us. We have got our international advisor, Dr. Rafique Ahmed sir, and we have got some distinguished faculties with us. We have got two elegant speakers today with us, Dr. AKM Monwarul Islam, Associate Professor of Cardiology, NICVD, and Dr. Umme Habiba from NICVD Dhaka. And later on, we have got some other faculties, including Professor Chowdhury Hasan sir, who will show us some issues. At the beginning of the session, may I request Professor Abdul Wadud Chowdhury sir to say a few words about today's session and about our speakers.
Good evening, everybody, and Assalamu alaikum. And good morning to Rafique sir and Hafiz bhai. And today we are going to again have some case-based discussion. Last week, we had very lively interactive session. Today, we are going to have similar sessions. And the presenters, Dr. Monwarul Islam and Umme Habiba Ferdaushi, both of them are very good and adept in their ECG interpretation and presentation. So I think we'll be enjoying the session very much. And as always, Rafique sir and Chowdhury Hafizul Hasan sir will be guiding us to proper interpretation of the things that are manifested in their presentation, that they will be describing. So without much ado, I think we can go to the presentation by the elegant speakers. Firoze, তুমি বলো ওদের কি করো?
The first speaker will be Dr. AKM Monwarul Islam. Dr. AKM Monwarul Islam is a renowned, now by this time, a renowned teacher, academician, non-invasive cardiologist. He is very much expert in ECG, clinical cardiology, and echocardiography also. He is working as Associate Professor of Cardiology in NICVD. May I request Dr. Monwar to share his screen and go for his presentation.
Thank you, Firoze bhai. Respected teachers and dear colleagues, Assalamu alaikum. I really feel privileged to be invited here to present some ECG cases. The cases which I am going to present today are mostly known to all in this form or in other forms. I think this session will be a recapitulation of what we already know. I like to first show some ST elevation cases, but they may not be of same etiology. Let us see what is in my hand. This is the story of a 55-year-old farmer who presented at Rajshahi Medical College Hospital with cardiac arrest. And this was the ECG of the person. Actually, while the patient was working under the sun in the field, he just collapsed and he was brought to the Department of Emergency of Rajshahi Medical College Hospital hurriedly. And this was the ECG. I think you all agree with me that this is a case of torsades de pointes followed by ventricular fibrillation. And when defibrillation was attempted, this was successful. And this was the post-defibrillation ECG. And seeing the ECG in the CCU of that hospital, the duty doctor made the diagnosis of acute anteroseptal MI with right bundle branch block. And accordingly, streptokinase was given. But when the case was followed up, troponin I was negative, and the day after the incidents, echocardiography was done and there was no wall motion abnormality. Just because of the discrepancy between the clinical presentation and the ECG and the other tests, the case was re-evaluated. And after close evaluation, it was obvious that there was a downsloping ST segment elevation, that is coving type in V1, V2, and V3. And the patient was actually having recurrent palpitation, atypical chest pain, and occasional dizziness, especially when working under the sun. And after further query, it was obvious that there was almost similar ECG with one of his sons. So the patient was a case of Brugada syndrome. And seeing this, the sample of the patient was sent to the Ramon Brugada laboratory, and subsequently a new mutation was recorded, which was underlying the Brugada syndrome with a novel missense mutation, and the case was reported in Indian Heart Journal. If we go back to the background knowledge, there may be three types of ECGs in Brugada syndrome: just type 1, type 2, and type 3. Type 1, the ECG which I showed was actually of type 1. And this is like this one. And this is the most specific one for the diagnosis of Brugada syndrome. And type 2 actually has saddleback shaped appearance in the ST segment. And the type 3 is the least specific. And in most of the time, it may be of normal variant. Still, this may be of one type of Brugada syndrome. The next patient is a 10-year-old boy who presented with palpitation and shortness of breath. And he presented to the pediatrics department of NICVD, Bangladesh. And this ECG was recorded during a worse episode of that young boy. And if you look at the ECG closely, I am sorry that the graph is not so obvious, but despite the drawbacks, I think you will agree that that patient was at that time of presentation was having wide complex tachycardia. And most probably this was a case of ventricular tachycardia. Why I am telling that this is a ventricular tachycardia, along with other features, there are some fusion beats or chimeric beats in some places. So the patient presented with ventricular tachycardia, and the patient was managed with defibrillation, and this was the ECG obtained during sinus rhythm. The ECG, if we look at the V1, there is again bundle branch block type, right bundle branch block type ECG in V1. And if we closely look at the ST segment, there are some notches in the ST segment, and the diagrammatic presentation of the notch is here. Just keep this in your mind, and then I am going to proceed further. When echocardiography was done, this was the recorded clip of the boy, young boy. You are seeing that the right heart is dilated, and the systolic function of the right heart is poor. And the free wall of the right ventricle is having more echogenicity. And also there may be some sorts of outpouching, that is aneurysm formation on the outer wall of the right ventricle, consistent with the diagnosis of right ventricular admogenic dysplasia or cardiomyopathy. This is the short axis view, and you are seeing obvious non-coarctation of the tricuspid valve. This might be the end of the story, but this is not so. Look at the hair of this young boy. This hair is not what we regularly see in our young chaps. the hair is to some extent peculiar. And in the close-up view, this hair is like this. This is to some extent woolly hair. We also examined the patient closely, and to our astonishment, the palms and soles of the patient had some sorts of skin lesions. And these are the keratotic skin lesions present in the palms and soles. Seeing these things, we tried to correlate all the things into some sorts of syndromes. And then we found that this was actually a case of Nexus disease. And this is one type of cardiocutaneous syndrome. This is a congenital or genetic abnormality. And this is obviously very rare. These sorts of abnormalities are very most commonly seen in Greece. And Naxos is actually an island of Greece. And this was probably the first case of Naxos disease reported in Bangladesh or from Bangladesh. If we consider the two types of right bundle branch block with ST segment elevation in the two patients just described, the left panel is of Brugada type, and you are seeing the right bundle branch block pattern and the characteristic ST segment coving pattern. And here, the next one, the second case. And in the second case, in the ST segment, there is a bump, and which is consistent with epsilon wave. So sometimes looking at the V1, V2, and the pattern of right bundle branch block and the ST segment and the minute details in the ST segment or in the nearby segments, you can find some exceptional things. And you have to have this in your mind, otherwise you may miss this. One very closely encountered and rather common ECG finding is early repolarization. We all see this in our day-to-day practice, as is the case presented here. This is the ECG from a young person, and there are ST segment elevations in many leads, in many of the precordial as well as the limb leads. And seeing this, the patient was initially thought to be a case of ischemic heart disease, but after initial management, ETT was performed and the patient did exercise up to the stage 5. Now, what are the recognizing features of early repolarization? The most important features are presence of NQRS notching like here. Some persons call this at fishhook appearance, or sometimes there may be some sorts of slurring in the end of the QRS complex and near the meeting of the ST segment. So these patterns may actually indicate that the subject is a case of early repolarization. Here, the 4 important types of abnormalities of ST segment and J point are presented here. This is, as I have already mentioned, early repolarization, and this is the Brugada type 1. And here, this is the epsilon wave of the ARVD, arrhythmogenic right ventricular dysplasia. This is not present in all cases of arrhythmogenic right ventricular dysplasia. It is found nearly half of the patients of ARVDs. And in the last one, and the lowest one, is the Osborne wave. Another name of the Osborne wave is the J wave. And this is characteristic of hypothermia, though this may be found in other conditions as well. In the realm of ECG, there are 2 J's. One is J point and another one is J wave. And you must have clear idea between the 2 terminologies. They are not same. J point is present in all patients with ECG, because in all patients, you should have a QRS complex and ST segment. And J point is nothing but the meeting point of the QRS complex and the ST segment. This may be isoelectric, this may be elevated, but this may be depressed, but the J point is the meeting point of the two entities of the QRS ECG complex. On the other hand, J wave is not so commonly present. This is rather uncommon finding. And this is sometimes present at the meeting point of the QRS complex and ST segment as a bump, like here. This is the J wave. And the synonym of the J wave is Osborne wave. This may be even found in normal persons, but historically, it was described in a case of hypothermia. It may be encountered in hypercalcemia as well. After this, I am going to present a very interesting phenomenon. Where there is no ETT, this may not be so a problem in USA, but in Bangladesh, still there are many districts where you cannot get ETTs. Out of 64 districts, in some districts there may be no ETT. And in that case, something may be better than nothing. This is the story of a 30-year-old man who presented to a practicing cardiologist in a district hospital. And this was the initial ECG of the patient. You all agree with me that we are dealing with a normal ECG, and this is a normal ECG actually. But the patient was complaining of chest pain. And when the complaint could not be discouraged or overlooked, ultimately that cardiologist did some interesting thing. He asked the patient to climb up the chamber several times. And then he repeated the ECG. And this was the ECG post-exercise. Just this was done in Feni. Though the patient was just of a 30-year-old age, but there is obvious ST segment depression and T inversion affecting most of the leads, the precordial leads as well as the inferior leads. And then the patient was referred to Dhaka. After the background, the patient underwent formal TMT in a posh center in Dhaka. And this was the initial picture. And in the stage 2, you are seeing these sorts of changes, which are very similar to the second ECG at Feni. And this was the ECG in the recovery stage, recovery 2. And the ST segment and T wave changes persisted even in the recovery stage. When I found this, just one interesting history I remembered. I am telling about the master 2-step exercise stress test, which in some form I first saw when I was a student of Dhaka Medical College in the private chamber of Professor Sheikh Nesaruddin Ahmed. And this is not the picture of Nesaruddin Ahmed, sir. This is the picture from the Mount Sinai Hospital of New York, where long ago in 1929, just Dr. Master did a very interesting thing. He thought that those healthy patients with no changes in resting ECG, but with some suspicion that he or she might have ischemic heart disease, he did ECG in the resting stage as well as after doing significant exercise in the form of climbing up the stairs and then down and then up and down and then repeating the ECG. And this was the first attempt to perform the exercise stress test. Now, this is the case of a middle-aged man with temporary pacemaker. I request you to observe the 3 ECGs I am going to present meticulously. The patient was admitted in a ward of NICVD, Dhaka. And on the 3rd day of admission, when the patient was on TPM, the ECG was found like this. Look at the ECG. And in this ECG, there are some pacing spikes. And after the pacing spikes, there is QRS complexes. And this phenomenon is repeating in a regular fashion. So this ECG is with TPM on. And then TPM was off and the ECG was repeated. And this was the ECG. I am going back. This was with TPM on and this is with TPM off. When we tried to correlate the 2 ECGs, we thought that there might be some sorts of explanation. No doubt that the TPM is not in right place and that is not performing the right job. So the patient was taken to the CCU and ultimately repositioning was done. And this ECG was after repositioning of the TPM. And in the lower row, just this tracing is showing that there is good capture and the TPM is working well. So if we try to complete the story, probably the TPM lead was displaced from the RV and then it entered into the right atrium and it was in contact with right atrial wall and there it was performing just pacing. This was the atrial pacing and luckily the AV node conduction was okay, and due to the intact conduction of the AV node, the subsequent impulse propagation was okay, and we are getting a regular narrow complex QRS complexes. And here, the patient, when the TPM was off, normal sinus rhythm was going on, and the sinus impulse was conducting across the AV node in a normal fashion, and the ventricle was being stimulated. What is the proof? Because in this case, there is AV association, no dissociation, and the PR interval is fixed, though a bit longer than the sinus node PR interval, sinus rhythm PR interval. And the QRS complexes are similar in both the cases. So that was the TPM lead was displaced and was in contact with the atrium, and it was performing stimulation, and the impulse was getting entering into the ventricles across the AV node, and ultimately this ECG was produced. And when the repositioning was done, this time the right ventricle was being stimulated from the apex, and what is usually we expect is getting here. Now, a young lady with chest pain. Look at this. This was the ECG during chest pain of that lady. If we closely look at the ECG.
Monwarul, can I ask you a quick question?
Yes, sir.
When you did the fluoroscopy, where was the temporary lead? Was it in the atrium or in the coronary sinus?
It was in the atrium.
Oh, okay, thank you.
Thank you, sir. Look at this ECG with that lady. There was pathological Q wave in lead 2, lead 3, and also lead AVF. And if you look at the precordial leads, there are either non-progression or some QRS, the pathological Q waves affecting the lateral leads. So this is very logical to think of presence of myocardial infarction with that patient, with that lady, though young. And when echocardiography was done, this was the recorded clip of that lady. And I think you will agree that this was a case of left ventricular hypertrophy. And most probably, if we consider this asymmetrical septal hypertrophy, so this patient was a case of hypertrophic cardiomyopathy. What is the purpose of presenting the ECG? Hypertrophic cardiomyopathy ECG may mimic myocardial infarction. And by this time, many of you may be familiar with the term pseudo-infarction. There are some cases in which the ECG may mimic myocardial infarction, but in reality, that was not due to MI. Those cases are called pseudo-infarction. There are a number of causes of pseudo-infarction, including left ventricular hypertrophy due to any cause, or hypertrophic cardiomyopathy, or still there are some other causes. I will show you another case. Again, this is the story of a 35-year-old lady who was admitted into Sir Solimullah Medical College Hospital for chest pain. And look at the ECG of the lady. There are pathological cues in lead 1 as well as in lead AVL. So apparently this was, and along with there was a T-wave inversion, prominent T-wave inversion, mimicking some sorts of bilateral MI. And also there are ST segment changes in the lateral leads, but the troponin again was negative. And this was the close-up view of the ECG of the lady. Again, echocardiography revealed the diagnosis of hypertrophic cardiomyopathy. No wall motion abnormality with these two cases. In no wall, in no segments out of 16 segments or 17 segments. So you should always be aware of making a diagnosis of pseudo-infarction whenever you are seeing such types of ECG in a especially young persons. Now, a middle-aged man who presented with progressive dyspnea, fatigue, and pre-syncope. And this was the ECG of the patient. What is the diagnosis? Apparently, it looks normal, except presence of low voltage. What is the definition of low voltage? Low voltage means either the QRS complex length is less than 5 millimeter in all the limb leads or in all the chest leads. Either of the two criteria may satisfy the definition of low voltage ECG. If you get low voltages on the leads, that is obvious that you are dealing with a low voltage ECG. And by this time, we know that there are a number of causes of low voltage ECGs, from gross hypothyroidism to obesity to other phenomenon. The patient, when echocardiography was done, this was the recorded clip of the patient. You all agree with me that this is a case of significant left ventricular hypertrophy. And another thing that is obvious from the short axis view, especially, that the left ventricle is not contracting so well. So the patient is having significant left ventricular systolic dysfunction, at least. May have diastolic dysfunction, but from this we can assume that this patient is having significant left ventricular systolic dysfunction. Look at this. This is the subcostal view. This is the hypertrophied septum and the lateral wall, and this is the wall of the right ventricle. And the right ventricle is also hypertrophied. And obviously, there is a mild pericardial effusion. And if you look closely at the interatrial septum, this is the appearance of the interatrial septum. So the interatrial septum is also thickened. By this time, we are seeing biventricular hypertrophy, enlarged left atrium, and the thickened interatrial septum, and also mild pericardial effusion. When left ventricular ejection fraction was thought of, it was just 36%.
Monwar, can I ask, can you go back to the
Yes,
other
sir.
echo?
Yes, sir.
Is there anything else in the septum, or am I imagining it? If you look at the shadow looks different, kind of speckling. Is it?
Yes,
I
sir. Yes,
I don't.
sir.
Oh, all right.
Yes, sir. Yes, sir. You are absolutely right, sir. If we look at the appearance of the myocardium,
Yes.
this is not what we usually expect. Rather, the appearance of the myocardium is granular. This is rather granular, just fine speckles, not coarse speckles. This is fine speckles in the form of granular appearance. And this granular appearance has affected the hypertrophied myocardium of virtually all the chambers of the heart, including the interatrial septum.
Thank you.
And now, with these normal cavity dimensions and such degree of hypertrophy, surprisingly, the systolic function is impaired, and this is moderately impaired. And when strain imaging was performed, this was the appearance of the strain imaging. And you know that this is a very characteristic condition, virtually pathognomonic of the diagnosis of cardiac amyloidosis, as far as echo is concerned.
Yes.
Left ventricular DLS was moderately reduced, minus 9.4%. And for your recapitulation, the normal value is up to minus 18%. And in case of cardiac amyloidosis, the periphery is characteristically affected and the center is spared. And this is very characteristic for the diagnosis of cardiac amyloidosis. This is the ECG from another patient with cardiac amyloidosis. Look at this. The low voltage affects the limb leads as well as the precordial leads. And the difference from the case presented just now is that there is bundle branch block pattern here, just left bundle branch block pattern here. This sorts of conduction abnormality is also very commonly encountered in cardiac amyloidosis. Now, another patient. This is not cardiac amyloidosis, 50-year-old man with long-standing hypertension. This is very common in our day-to-day practice. And you will agree with me that this ECG is nothing but a ECG of left ventricular hypertrophy with strain, which is consistent with the long-standing hypertension. And here, the recorded clip is giving the impression of left ventricular hypertrophy, significant left ventricular hypertrophy without any apparent obvious wall motion abnormality. And here, the ejection fraction was preserved. This is 64%. And global longitudinal strain was virtually normal, minus 17.2%. And look at this. If we go back to the previous case, the red color means normal. The lighter color means there may be some sorts of perfusion defect. Another ECG from a 52-year-old man who is normotensive, minded normotensive, but he presented with syncope. And this is the ECG. Apparently, this ECG and this ECG is very closely related. But here, the ST segment and T inversion affects in most of the leads. And certainly, we have to correlate at the bedside whether the patient is having long-standing hypertension or not, or the precordium is having any systolic murmur or some sorts of murmur or heaving type of apex beat or not. Just in this case, this patient was normotensive, no history of hypertension. And this was the echo. This is the hypertrophied septum. And also the other parts of the left ventricle was hypertrophied, but septum was disproportionately hypertrophied. And incidentally, there is a Chiari network here. Look at this. This worm-like structure within the cavity of the right ventricle, right atrium, is Chiari network. Some persons call it Chiari network. And this is the virtual obliteration of the cavity of the left ventricle during systole. This is the systolic anterior motion of the anterior mitral leaflet, and the gradient, left ventricular outflow tract systolic gradient was 117 millimeter mercury. And there was mid-systolic closure of the aortic valve, which is one of the important echo features of hypertrophic obstructive cardiomyopathy. And this is the strain imaging pattern of that condition. And here, the apex and other parts are more or less spared. So, if we go back to the three conditions, there are two significant differences. The first case presented with low voltage ECG, but the echo showed gross hypertrophy affecting the both ventricles. And the second case showed hypertrophy in echocardiography, and the ECG was also concordant. That is, there was also hypertrophy in the ECG. This is expected, but there is dissociation between the findings of ECG and echocardiography. So whenever you are encountering such sorts of discrepancy, the diagnosis may be cardiac amyloidosis. So the dictum is, whenever you are dealing with low voltage ECG in a patient with left ventricular hypertrophy, always think of cardiac amyloidosis. And this is the last case from me today. Thank you all. I like to conclude my presentation with some recitation from Dijendralal Rai. Chandra Surjo Groho Tara, Kothai Amon Ujol Dhara, Kothai Amon Khele Torit, Amon Kalo Meke, Tara Pakhir Dake Ghumi Pore, Pakhir Dake Jage. Amon Deshti Kothao Khuje Pabe Nako Tumi, সকল দেশের রানী, সে যে আমার জন্মভূমি, সে যে আমার জন্মভূমি, সে যে আমার জন্মভূমি. Thank you all for patient hearing.
Monwarul,
Sir,
can you go back to the pseudo infarct pattern of the ECGs, please?
তুষার, তোমারটা অফ করো।
first one or second one?
Yeah, first, let's start with the first one. Okay, so I'm sitting in front of you. I'm a MD student for the final exam, and you show me this ECG, and I call it sinus rhythm, old inferior, and anterolateral myocardial infarction. And I have no other information, and you have no other information. Will you have any objection to that diagnosis?
Probably
And
no.
Huh?
Probably no.
Why probably one was? It's no. No objection. It should be
As
no.
there is no other information,
Yeah,
so I think the diagnosis.
One can put differential diagnosis with this.
Yes, yes.
But other possibilities. But this is what Rafique sir said. That is the diagnosis of the
Yes.
ECG diagnosis.
Yes, yes, yes.
Any other faculty, any objection or comment? Because I want everybody to take a message home, the young doctors.
Sir, there is short pair. If we see the ECG,
No,
in
it's
No short pair.
Short pair.
Sir,
Mistake is there is no.
Pair interval is normal.
The thing is, sir, during
slurring মনে হচ্ছিল স্যার
No.
something during exam time, if the student say this is a shoot infarction, I will fail that to student. I will say, you know, about the patient.
Yes, sir.
Because for ECG, he has to say there is Q waves in lateral leads and inferior wall, and there is poor progression of heart wave. So the patient is both inferior MI, old inferior MI, and old anterolateral wall MI. That's the answer I would be expecting from the ECG alone. Then I would be giving him some scenario. If you say if the echo is normal and the patient is a 30-year-old, what could be the other possibilities? Because you don't see any ECG, any evidence of MI in the echo. Then we can have a discussion. But the ECG is straightforward. I would want that answer.
Thank you. So I think this is important for us all to understand, and especially young doctors, that we will say pseudo infarct pattern after I have excluded acute myocardial infarction. Monwarul, you'll agree with that, right?
Yes, sir. Yes, sir.
Yes. Thank you. So this is a QS pattern, and that brings us. I mean, we have been talking about the differential diagnosis.
Yes,
I think we are forgetting clinical medicine all over the world. I think every time I diagnose something, there must be some alternate diagnosis in my mind. And if I don't have that, then there is a problem. I mean, this can be a patient with acute MI with HCM also, right? So
Yes,
please
sir.
remember differential diagnosis. Thank you. Thanks, Mohammad.
Sir, Rafique sir, may I ask a question, sir?
Can I make another comment?
Sir?
Yeah.
You were saying
I have an observation here that in AVR there is a RS and R pattern, and in V5, V6 there is a QRS pattern. Does it mean anything new?
I mean, this is the fragmented signal. And so if somebody has myocardial infarction or hypertrophy, you will see the signals fragmented, and that's what it represents.
Sir,
Yes, thank you.
somebody was saying there cannot be global MI. We are not talking about acute MI. This is the T wave are upright. So this is a case of old MI, if you want to say MI. So there can be MI once at a anterior wall, again in the inferior wall. So it doesn't mean it's global MI. Hassaner was putting that question, but I would be answering it that way.
Thank you, Dr.
This is wonderful presentation, Monwarul.
Sir.
Wonderful job.
Thank you, sir. Thank you, sir.
Thank you.
Should I stop
I think
sharing?
you can stop sharing your screen. Yes.
Yes.
And Atahar Ali sir to
Thank you, Firoze. Actually,
comments on Monwarul's presentation.
Actually, it was an extraordinary, wonderful, excellent presentation. I learned a lot of things from today's presentation. Monwarul, congratulations. Actually, the presentation was more than what I expected. Really, it was so. It gives so much of a message and information to us that really very excellent. Just I want to know one thing from Monwarul. Monwarul,
Yes, sir.
You're the second case, that is the nexus disease.
Yes,
Is
sir.
there any difference between the nexus disease and the RP cardiomyopathy? Is there any difference?
Sir, all nexus disease cases present with RV cardiomyopathy, but not all RV cardiomyopathies are nexus disease. Because RV cardiomyopathy is an entity that need not have the skin and hair changes. But if you encounter some special types of RV cardiomyopathy with some special types of affected genes, those have triad of right ventricular cardiomyopathy along with palmoplantar keratoderma and also the woolly hair. This combination is called nexus disease. And if the same phenomenon affects predominantly the left ventricle, that is not nexus disease. That is Carvajal syndrome. And we all know that the current changing in the terminology not ARVD, arrhythmogenic right ventricular cardiomyopathy. The term is going to be replaced by arrhythmogenic cardiomyopathy, ventricular cardiomyopathy, arrhythmogenic ventricular cardiomyopathy, because many cases of ARVD actually affects the left ventricle as well.
Thank you very much, Manwar.
Thank you, Dr. Manwar. Thank you very much for your presentation. I think we can move on to the second presentation. May I request Dr. Umme Habiba Ferdaushi to share her screen and go for her presentation. Dr. Umme Habiba, please.
Thank you all.
Habiba, you have to unmute yourself as well.
Doing that.
And share the screen.
Is my screen visible?
Not yet.
এই যে সবাই এখন বাচ্চাদের ডাকতে গেছে, এছাড়া উপায় নাই।
আমার তো বাচ্চা ডাকে না।
Dr. Habiba, share your screen.
Is it visible now?
No, you are visible, not your screen.
Not my screen.
Yeah. You look at the lower panel of the Zoom. There is a green arrow upward. Share this.
Yeah.
Click that one. Click that
Not
one.
visible now.
Presentation ta desktop e open korso?
Yeah, now it's coming.
Now it's visible. Now it's visible. You can go for it. Okay. Go for the slideshow mode. Slideshow mode e dekhao.
Yeah.
Yeah, ঠিক আছে.
Okay. First take it short off. Oh. Hello. Am I audible?
You are very well.
Okay. Hello, Assalamu alaikum. I am Dr. Umme Habiba Ferdaushi, working at NICVD, Dhaka. And outside, I would like to express my sincere gratitude to the ECG study group, especially to my teacher and my mentors, Professor Atahar Ali and Dr. Wadud sir, and also Dr. Firoze sir and Rafique Ahmed sir, for giving me the opportunity to present in front of this prestigious panel. So I also like to welcome my respected teachers and my senior and junior colleague to enjoy the session and make it interactive. I'm going to present two cases. So with the permission of my moderator and our chairpersons, I would like to start the case. So here's my case one. A 45-year-old male smoker, normotensive, diabetic, came to us with progressive central chest pain with sweating, with no history of vomiting for 2 times. On examination, his hemodynamically stable, blood pressure was 110/680. So this is his first ECG. So if I try to interpret this ECG, I can see this is sinus rhythm. Rate is about 60 beats per minute, and the PR interval is short with a small delta wave in the beginning of the QRS complex. The QRS complex is a little bit wider, and there is some STT changes, that is ST depression and T-wave inversion in the anterior lead. Probably these are due to secondary to Wpw pattern. So we all know this is a ECG of Wpw pattern Ecg, which means this patient has an accessory pathway. That is his atrial conduction from atria to ventricle is through some accessory fibers, and which is manifest one. That's why the ECG is like this. So if I try to locate the location of the accessory pathway, we all know there are a number of algorithms to locate the ECG accessory pathway, and among them, Aruta's approach is a familiar one, and it is sensitive about 90% and specificity is 99%. So, according to Aruta's approach, if we follow the step 1, that is in the we have to see the lead 1, and if the delta wave, if it is in the lead 1, isoelectric or negative, then we have to see the V1. In V1, if RS ratio is more than 1, that is, if R wave is more than greater than S wave in V1, then the accessory pathway location is the left free wall. And in the left free wall side, whether it is anterolateral or posterolateral, to know that we have to see the AVF lead. So in AVF lead, if delta wave is positive, then it is in the anterolateral wall, and if it is negative, then it is in posterolateral wall. So in our patient, we thought this is a Wpw pattern Ecg, and accessory pathway is left-sided, left anterolateral side. But our patient come with progressive severe chest pain with sweating. So we decided to follow this patient for some time. And luckily, we got this second ECG. And this is the, again, the same delta waves are there, ECG, Wpw pattern ECG. But here we can see in lead 2 and 3, the second and third beat is, interestingly, these are normal sinus beat, and normal sinus beat, and there is peer interval is normal, and there is no delta wave. And if we see lead 3, we can see the ST elevation is there. So this time we become a little bit confused regarding the management of patient, because only one lead, we can't decide whether we should go for STEMI management or not. So we decided to follow the patient, and finally, after some time, we get this ECG. And this is very interesting. This becomes sinus ECG. And here is frank ST elevation in the lead 2, 3, and AVF. Also reciprocal change in the AVL, that is T inversion. And also in V1, 2, and 3, there's ST depression with positive T wave. So all indicates that this is a case of infraposterior MI STEMI. So we manage the patient accordingly as STEMI, and we reperfuse the patient, that is thrombolized. And this is the discharge ECG. Here we can see there is Q wave in the 3 and AVF, and reperfused T wave inversion in the inferior lead. So in summary, actually, this was a case of infraposterior MI, and the patient presented with Wpw pattern ECG, intermittently conducting some times and masking the infraposterior MI. So ECG should be interpreted very carefully with clinical correlation, and history taking is a crucial part of the management of patient. And keen observation with serial ECG along with symptom analysis is the key part to guide the ACS patient management. So this was my first case. So if any discussion from the panelists, we can continue now, or I may go to my case too.
Firoze, I think this is very interesting case, and we should take 1 or 2 comments from our panelists for this ECG.
Okay, sir.
First of all, Habiba, do you have any explanation for this normalization of the delta wave?
Yeah, sir, I think this is a Wpw pattern ECG. This patient is 45 years and he has no episode of palpitations and no other complaint regarding this. And this conductivity, that means the conduction velocity of this accessory pathway probably lesser than the sinus pathway. So whenever in competition, the conduction goes through the AV node, then the pathway, accessory pathway become concealed. The conduction become retrograde.
Firoze. Hello, Firoze.
Sir.
Hello. I said we
Yes.
think we should take two comments, one from Wadud bhai and then finally from Rafique sir. Wadud bhai.
Probably sir is busy with phone. I think
Right.
Abdullah Jamil sir can
Sir,
make comments, sir. Jamil sir.
Jamil.
Probably the infarction involved the area where the pathway was, and that infarction abolished that pathway and it get normalized.
I think we should take the
There is one
Rafique sir
explanation.
finally. Firoze, I was expecting the explanation. Rafique sir's comment.
Can you show me the next ECG, please?
So which one? First one?
Yeah, this one and the next one. I mean, you can have intermittent accessory pathway conduction. That's not very unusual. But I think this was a good presentation. I think it brings us to clinical medicine, that it doesn't matter what the ECG is, patient's clinical scenario is what is very important. And I think then what you notice, that subtle ST elevation, that is another thing that I think one of the most, we have seen inferior MI being missed because patient continue to have mild pain and there is minimal ST elevation in 2-3 AVF, which this patient had. I think this is what is remarkable. So, and that's the Wpw pattern probably is intermittent pattern, and we see in quite a lot in common practice.
Dr. Habiba, have you done the angiogram, coronary angiogram of this patient?
No, sir. Actually, we can't do that because the patient was discharged and they were not agreed to do the angio.
Because that will give you the artery involved, and probably that could explain the Dr. Jamil's comment. Which artery was involved?
But sir, I have a question to Rafique sir. Sir,
Yeah.
Why sometimes WPW become present as intermittent?
Oh, it depends. The question is why WPW pattern becomes intermittent. It is not very uncommon. The question is preferential conduction. If you look at the AV node, and this is the lateral pathway, left lateral, the P wave will reach the accessory pathway much later. And if the AV conduction by that time has been accomplished, it will go and retrogradely penetrate the accessory pathway and block it. Because that takes about 80 milliseconds. So if you think about going through the AV node and then going to the lateral wall, that's about an 80 millisecond time. And you can do that. So it's depending on the accessory pathway and the AV node refractory period ratio.
That means the conduction velocity is important. Is it the fact is like this?
Velocity? Yes. And if you see that at a faster heart rate, this had WPW conduction, but that was not true. That's what I was expecting. You can also see that at a slower rate, it also still had conduction.
Yeah.
So the other possibility is that this is an inferior MI, and you are affecting the AV node more than the accessory pathway. And once the AV node conduction improved because you reperfused, it conducted mainly through the AV node. So the accessory pathway did not change. The AV node conduction changed probably.
But in this ECG, sir, when we get the ST elevation and there is no delta wave is there. Yes. So this is the ECG before reperfusion.
Yes. So I mean, this patient, the problem is we don't have an angiogram. So we do not know how much obstruction there was. Or is it a vessel that was a blood clot which was opening up and closing? You know, we see all these cases with unstable angina. So that's why it would have been very important to get in. But as I told you that even without my MI, we see intermittent accessory pathway conduction. That's not an uncommon phenomenon.
Sir, during this acute coronary syndrome, can it be the explanation, sir, that the acute ischemia has changes the conduction velocity of the accessory pathway? That is your explanation, that is the AV node conduction improves, or alternatively, the conduction through the accessory pathway decreases. Can it be, sir?
It's a, yes, theoretically possible. But think about the accessory pathway. It's a tiny pathway on the lateral wall and near the endocardium, not epicardial. for that to be affected, you have to have that vessel involved specifically.
Right.
And a patient will be very lucky. I mean, if that place infarcted, then patient will have no subsequent accessory pathway conduction at all. And if that is the case, then he is lucky. He's very lucky.
Thank you, Habiba. Next case.
Thank you, sir. So, this is my second case. Patient 60 years old male smoker, hypertensive, diabetic, came to us with severe chest pain followed by syncope. On examination, patient was hemodynamically unstable. BP was 70 millimeter mercury. That means only single blood pressure marker we can record. So this is his first ECG. So if I try to interpret this ECG, this is a wide complex regular tachycardia. The rate is about 200 millimeter of mercury, sorry, blood BPM. And this is, if we follow the Brugada criteria, this is concordance in the precordial lead, and axis is right axis deviation, and there is some dissociation. Probably in the AVR, we can see the P wave. This is dissociated P wave. So in my interpretation, this is VT, and as patient is hemodynamically unstable, we try to cardiovert the patient. We cardiovert the patient actually, and this is the ECG after cardioversion. Another thing, in this ECG, you also observe there is a small Q wave in the V1 and V2, and we also see the QRS complexes are not, that means fractionated. So post-cardioversion ECG is this. And here we can see this is a junctional rhythm. Rate is about 100 beat per minute. That is, it is junctional tachycardia, and QRS complexes are wide. And this is complete RBB pattern with left axis deviation. And there is also tiny Q wave in the V1, V2, and there is poor progression of R wave in the anterior leads. And also,
can I ask you a question about this ECG? Yes, yeah. Possible junctional rhythm, but what happens if you look in the bottom strip?
Yeah.
Where the sign V3, please come down below that in the rhythm strip. There is a P wave followed by a QRS complex.
V3.
Please continue.
Is the 10th beat?
10th beat.
Yeah.
In the rhythm strip.
Acha, in the rhythm strip. This one, sir.
Continue on the right. No. Continue. Next.
From the right.
This one.
From the right,
left.
From the right, the fourth one.
Yeah, sir.
Habiba, from the right, fourth one.
Left, Habiba. One bit left.
Yeah.
This one, sir.
Yes.
The one before, you know, where your marker says V3.
Okay.
Just come below V3. Below V3 on the rhythm strip.
Yeah, this one.
Yes.
Yeah,
this one?
Yes.
Yes.
So actually, there are some P waves are there. I feel so. This is like this one. But I think this is not regular one. It is like bizarre dysmorphic P wave. That's why I would like to say this junctional rhythm.
Okay. So let's make an assumption. This is junctional rhythm. But the beat that I mentioned, that's a conducted QRS.
Yes.
And if that is the conducted QRS, the junctional beat should have been the same morphology. But it is not.
Yes.
So is it possible that that was a slow VT? And if you continue next beat.
Yes.
From that beat, next one, next one is a fusion beat.
Yes.
So
P wave is there again.
yes, so I mean, my feeling is that this was underlying sinus with a slow VT, and there is some captured beat and some fusion beat. This is a perfect example of for teaching fusion and capture beat.
Yes,
Yeah.
sir. Exactly, sir. And in junctional rhythms, the QRS complex would not be so much wide.
Low junctional rhythm, sometimes QRS complex become wide.
Sir,
But
could
it's quite wide.
rhythm?
What is it?
Can we tell it as idioventricular rhythm?
That may be.
The question is, it's a semantics. If the rate is over 100, we call it slow VT. If the rate is below 100, so it's basically a question of semantics. But okay, thank you. Next, continue, please.
Okay, then we see the progression of our. Actually, all the findings I describe, it all may be due to post-cardioversion ECG, but this patient has anterior Q waves and RBP and left axis deviation bifascicular block. So after that, repeat ECG, we get DCCG.
This one is sinus rhythm.
So this is a sinus rhythm ECG, and here we can see the RBB has resolved, but left axis deviation is there, and there is widespread ST depression and reciprocal ST elevation in the AVR. And also there is Q wave in the V2 to V5. So we thought this is a case of acute ST elevated MI or where AVR is positive and multiple lead ST depression, which indicate probably left main disease or multivessel disease or proximal LAD disease. So we manage the patient accordingly. We just give him loading dose and pain management. At the same time, we give him low molecular weight heparin. And after that, we did the angiogram and we got proximal LA deletion. So this was the end of my second case.
What was the echocardiography report of this?
The echocardiography, the LV function was good. It was about 55%.
What about the
Ejection fraction was
myocardium?
55.
What about the myocardium? It was the echogenic one, thin one. Does it indicate a old myocardial infarction or like? Because the T waves in heart ECG is still upright.
Yeah, sir, echocardiography. I can't remember. Actually, probably the ECG, sir, echocardio. Yeah, sir, I remember. So in echocardiography, the anterior wall is echogenic, and the ejection fraction was 45 to 46%, just like that. So anterior wall is echogenic and thin, and we thought it was a
old myocardial infarction.
Old, yeah, sir, old anterior MI. We thought.
Not an acute one.
Yes, sir. But sir, my question is, so is it a case of acute MI over the old occlusion? That is because this AVR is positive and all the ST depression in all different multiple leads, that inferior lead and also the anterior lead are there. So,
tropi?
What, sir?
Tropi? Troponin?
Oh, so tropi was raised. It was 19
That's very
nanogram per TL.
Yeah. So this is an acute MI.
Yeah.
And why do you think the RBP was there? What does it suggest? That also suggests something. First septal involvement, very proximal LAD occlusion.
Very proximal LAD. Yeah, yeah, sir. Proximal LAD was occluded actually in angio.
So why did not thrombolytics? You did the thrombo, that is the low molecular heparin. Why not
So
thrombolytics?
actually, from the VT ECG, we thought it was a scar VT because there was some notched in the QRS complexes and also Q wave in the anterior leads. So we thought this is a scar VT. And when we get this ECG, that AVR is only AVR is positive when this is. So nowadays, so the guideline says that in 2013 guideline that DC is ST equivalent, but nowadays recent guideline says that it may present with multivessel disease or in acute setting. This is a urgent management, but this is not an emergent management. So early angio is recommended, but thrombolytics is not recommended.
The thing is, you may have said the echo shows thin-walled LV, is it?
In anterior wall, yes, sir.
How many days after you have done the echo? Because if it is thin wall, that means the patient had already had an MI and it is reinfarction.
Probably that's, sir, because in this setting we did the echo. So probably that was previous MI because he has no documentation.
What do we can see that troponin I can raise after cardioversion, DC cardioversion. What is the limit? Is there any limit?
This is 19 because this is 19 nanogram per DL. This is too much, I think. After cardioversion, it may raise, but little one.
That's the point, actually.
Firoze?
After cardioversion, we do not expect that much of a rise.
Yes.
Thank you, Dr. Habiba. You can stop sharing your screen. It was a very good presentation from you.
Thank you, Habiba. Thank you.
Thank you, sir.
Now, may I request Professor Chowdhury Hassan sir, Hafizullah Hassan sir, for his presentation. Chowdhury Hafizullah Hassan sir, please. Sir.
Hello, sir. Sir is having some problems with his microphone, probably. Chowdhury Hassan, sir. He contacted me. He's trying to reconnect again.
Then, Rafique sir.
Yeah, so what I'll do is that I will continue when Hafiz comes back.
Right, sir.
Then we'll let him do this. So in the meantime, I'll go back to just our old pattern that we're going to look at some ECGs and have the...
And have fun.
Yes. So this is the one.
You make ready your whole system.
Assalamualaikum, sir.
I was hoping that there will not be much of a distribution of this ECG. Wadud.
It is surprising, sir.
Yes. So this has been a random choice. I mean, if we see a photo of Professor Wadud, we cannot call him Professor Atahar. So this is what it is. This is a normal ECG. Please remember this picture. And if you see this picture without thinking, you call it a normal ECG. And then you try to explain this is not the twin brother of Professor Wadud. Yes. So this is normal ECG. So please remember a few things. We can see P wave before each QRS. We keep coming back to this. P wave before each QRS complex. P wave is upright in lead 2, 3 AVF, 1 AVL. Normal PR interval, normal QRS duration, normal QT interval, normal ECG. If we can identify this ECG, we have solved 90% of ECG in clinical practice, because 90% of ECG in clinical practice are normal ECG. So I'm going to bring it back again and again until we get 100% on this one.
Sir, can I?
Yes.
When we look at the ECG, let us look at the lead 1. P is upright, QRST quite all right. Lead 2, P is upright, so it's sinus. Every QRS has a P wave before that. Now, for the axis, lead 1 is upright, lead 2 is upright, it's normal. Lead 1 is upright, lead 2 is down, it's left axis. Lead 1 is down, right axis. Make it very simple, only lead 1 and 2, that will help you. And again, for left atrial enlargement, look at V1. It has to be wide, at least 1 millimeter wide, or depth should be more. Now, the point is, number 4 answer says, sinus rhythm, left atrial enlargement. This could be possible left atrial enlargement, but there is no left axis deviation. So this answer should be wrong, because part of the answer is wrong. So only thing that left to you, sinus rhythm, left ventricular block is not there, not left 3. Lead, number 1, sinus rhythm, left axis deviation is not there. The only answer left to you, which should be correct by default, is sinus rhythm, normal ECG. And we should memorize this type pattern, as Sir was saying.
Normal axis up to -30 degree, we consider as normal. So we can sometimes say left toward the axis, but it is still normal range. Next ECG. I mean, we encountered this, I mean, not that frequently, but it happens. The heart rate is 57. I think this is acceptable range of answer. Wadud is very good with this one. So I would like him to make comments why this is funny ECG.
Look at lead 1, the P wave is down. Look at lead 2, the P wave is upright. So what's wrong? Is it limb lead displacement? In AVR, the P wave is up, looking, and the second bit it seems to be. Perhaps this is lead displacement. Then there should be the P wave. Look at the chest leads. The R wave is progressing nicely from V1 to V6. So there is no dextrocardia. And this should be, all the P waves are before each QRS complex, sinus rhythm, but we have wrongly placed the limb leads. If it is ectopic atrial rhythm, the point is the ectopic atrial rhythm, where is the location? It's negative, it should be left atrium. If it's left atrium, that's the possibility, yeah, this is a possibility that the rhythm should be like that. And if it is left atrium in high up, then the P wave should be upright in the inferior leads. If it is posteriorly from high up, then there should be a positive P wave in the V1. So that's another possibility. But look at this, ectopic atrial rhythm, right axis deviation. So we could say that. But the first one would be the my first choice.
Yeah. So I think what Professor Wadud mentioned, mismatch between the chest lead and the limb leads. And I'm going to bring this picture up. This is normal pattern. I have marked sinus node here. So the electricity moves down and to the left. AVR becomes negative, AVL becomes positive, lead 1 is positive. Lead 3 is kind of funny looking, but AVF and 2 becomes upright. And if you look at lead V1 through V6, V1 biphasic, V2 can be biphasic or monophasic, and then it becomes monophasic. That's the normal pattern. Now, if this patient had a left atrial rhythm, 1 and AVL will be negative. So will be V6, V5, V4. It is not. So there is a mismatch. And I'm going to bring up this ECG again. So if you look at here, sorry, my pen is up. Okay, so lead 1 is negative. Lead AVL is negative. These two are negative. So it can't be true, because if this is negative, that means the active beat is coming from here. If this beat was coming from here, V5, V6, V4 should have been negative. So remember this mismatch. This is the commonest limb lead mismatch. It becomes a little bit complex when it becomes like left leg, right leg mismatch, and that becomes a little cumbersome. And the same patient, after normalization of ECG, this is what it is. Let me see if I can erase this.
Hassan is there.
Okay, good. Hafiz ke diya. All right, I'll unshare my screen.
Professor Hafiz, sir, are you?
Hafiz? What happened to Hafiz?
The possibility is
Call from Chowdhury.
Hafiz is having problem.
Call from
Hafiz.
Firoze?
Yes, sir.
না হাফিজ ভাই কি জয়েন করছে?
জয়েন করছে স্যার, দেখা যাচ্ছে।
Hafiz? Okay. All right. Okay, thank you. Hafiz is having problem with his microphone, so we'll continue.
Okay, sir.
Yes. Let me go back where I was. Okay. All right. So this one.
Sir, a question regarding the previous ECG, sir.
Yes.
Sir, actually, we teach the student, and our students always say that is the technical dextrocardia. Whether this term is acceptable, sir? Technical dextrocardia.
I mean, when you say technical dextrocardia, that means you are recognizing dextrocardia. It is not dextrocardia. It's a lead misplacement. Because putting that diagnosis in a patient's chart, we do not use it. We just say limb lead misplacement. So we don't use that term.
Right, but lead transposition.
Yes.
Like that.
Okay. So this one, I'm sorry, I can't get rid of that. Those markers, excuse me for that. So this one. Can you have the poll, please, on this for this?
Review pollটা দেখেন।
Yes, sir. দিচ্ছি।
Okay.
এই যে, sir.
So, Wadud, do you know that you can get laser pointer on the PowerPoint?
No. Sir?
Yes, so this I found out. So when you go to slideshow, right click and it will give you an option of either pen or laser pointer.
I know,
Yes,
sir.
sir, there are different options.
Yes, sir, I
Yeah,
can use it.
I didn't know. I didn't use it for a long time. Okay. So nobody is number 4, which is good. And then we have a distribution. I mean, all of them are reasonably acceptable answer. I wouldn't object to these. Definitely sinus rhythm, but I think we also need to pay attention to the P wave. That if you look at lead V1, there is a terminal portion is wide and deep. So that left atrial enlargement. Left anterior fascicular block is not there because look at the QRS axis. Lead 1 is positive, so it's on the right side. Lead AV is negative, so it's on the negative side. But lead 2 is more positive than negative. So it is close to, I mean, I can probably call it minus 10 degrees.
Yeah.
Or so. And with that level, we should not call left anterior fascicular block. The criteria for left anterior fascicular block, some people will say minus 45 degree with a small q in lead 1 and small r in lead 3. So this is not. So this is actually sinus rhythm, left atrial enlargement. So I would accept first 2 answer, but 3 I will not. So please remember that left anterior fascicular block diagnosis more than minus 45 degrees. Some people say minus 30 with a Q in lead 1 and R in lead 3.
Sir, ST segment in V1, V2, 3.
Yes, there is elevation. That is, look at the lead position. Probably V1 and V2, they have been very close to each other. And that minimal ST elevation in V1 and V2, you can see in normal pattern. Because I think if you look at lead V2, this lead has been placed very close to V1 because it still has a biphasic pattern, and even in V3. I think this is another problem that when we see poor ROA progression, the question is where are the leads placed? If the leads were correctly placed, you will not see this terminal in V3. It should have become positive. So there has been some problem with the lead position. Please remember, describing ECG is important. Sharpening our eyes. Okay, this is very good. So I think this is acceptable, right?
Nobody said normal. That's very good, sir.
Exactly. So this is not a normal ECG. This is sinus tachycardia. We have left atrial enlargement by lead V1. We have terminal P wave negative and wide, and in lead 2, 3 ABF, you can see tall P wave. And then, of course, heart rate is faster. So sinus tachycardia. That's good. Thank you.
Sir, can I ask a question, sir?
Yeah.
Sir, Wadud bhai, please. Sir, if we think clinically, there is biatrial enlargement, but there is no change in the QRS. Sir, what clinical situation can it be, Wadud bhai?
The thing is that there's sometimes left atrial enlargement alone may present the feature of biatrial enlargement. In case of sinus tachycardia, the P wave height is slightly increased, number 1. Number 2, the biatrial enlargement, we can see the second peak is higher here in lead 2. That also suggests it's left atrial enlargement. That's a possibility. And with biventricular hypertrophy, we know that ventricular hypertrophy ECG manifestation is not very sensitive. So that's one of the reasons we may not get the ventricular enlargement in the ECG.
Yeah.
Thank you. So next one. So this.
There is a terminology term poor progression of the R wave.
Yes.
What is the exact definition of this poor progression of R wave? How
Well,
would you define it?
Yeah, the question is from V1 through V3, you should see that the R wave getting bigger. By V3, the R should be taller than S. So here, if you see that it didn't go up, but then it jumps from V4,
yeah,
that's pretty unusual. So that means whoever put this lead did not put them right, because you cannot suddenly see such a big jump. So there must be a big gap between V3 and V4. Yeah. So that's the definition of poor R wave progression. And there are many differential diagnoses. The commonest differential diagnosis is poor lead position and LVH, myocardial infarction, rotation of the heart, or left ventricular hypertrophy can cause poor R wave progression. We have to keep those in mind. Thank you.
COPD, sir.
Huh?
COPD.
COPD. Okay, so this is a patient. This patient we just saw in the year. They called me. This is on the 12th of December. So she is 46, history of diabetes, hypertension, came to the emergency room just not feeling well. And no dizziness, no syncope, no palpitation, and no chest pain. And this is a 7-day history of not feeling unwell. This is the ECG. Then I'll give you the scenario, and the patient in the emergency room got adenosine, no response. And then patient was cardioverted one time, then go back to VT again, got a second cardioversion. So this is the spread of the atrial flutter with 2-to-1 conduction with the right bundle branch block, SVT. Yes, I mean, these are all the possibilities. We're going to come back, although we'll discuss it a little later. So we'll leave this. So what happened? This is the white QRS tachycardia. QRS duration is about 130 milliseconds. The right bundle pattern with left axis deviation. And the funny part is there is 1 to 100 to get conduction, and I'm going to show it to you. So I took this 4 QRS complex. You can see there is this is the retrograde P wave, and it is present in every lead. Now, of course, Hafiz will say, Rafique bhai, make things up, but I'm going to prove it later on that I did not make it up. So this is what it was. So the patient then, after the third shock, patient again went back to this white QRS rhythm, and ejection fraction was about 45%. We started intravenous amiodarone. My plan was that after maybe an hour of amiodarone, we will try to cardiovert again. But within an hour, she converts back. So VT, cardioversion, sinus, 3 cardioversion, then sinus rhythm, and went back to VT. As the patient was hemodynamically stable, we did not attempt any more cardioversion. We gave 2 boluses of 150 of amiodarone, and then started a drip. 1 hour later, converts to sinus rhythm. Post-conversion, ejection fraction 40 to 45%, and this is the ECG. Of course, sinus rhythm and T inversion in lead V3 to V6. Again, patient had no chest pain. And then that night goes back to this QRS rhythm again. And the question is, again, the same question I'm asking, see if the audience have any difference in opinion or not. Please wait before you pull the poll on. Let them have a look at it. better. More people calling. So the issue is it a supraventricular? I mean, first three choices are basically, is it a supraventricular rhythm with underlying right bundle branch block? So that's the issue. If you look at lead V1, in typical right bundle pattern, the initial R should be smaller than the second R wave. It is reversed. Second, it is a monophasic R wave in lead V1. That is unusual for right bundle branch block. So let's look at one more thing. So this time, I pulled up this PVCG. Look at this carefully. There is a P wave here. There is no P wave here. And there is P wave here. And this is actually other lead also shows the same thing. There is a P wave here, nothing here, nothing here. Now I have AV dissociation. So initially ECG actually had 1 200 to get conduction, but this one doesn't have. So that makes the likelihood of ventricular tachycardia more of a possibility. And then if we go to the morphology criteria of VT, in presence of right bundle branch block, V1 and V6, if it is monophasic R wave, which we have here, supports VT. In V6, if the RS pattern is less than 1, which it is VT. So this was actually ventricular tachycardia. And we did angiogram on this patient. What it showed that RCA had diffuse 50% disease, left circumflex, nothing much, LAD diagonal, obtuse marginal branch actually. One of the OM branches had 99% stenosis, but that was dissected and could not be stented. So this is VT, right bundle morphology VT. Please remember, it looks very narrow, right bundle. And the other clue to this is right bundle left axis deviation. This is another clue to the fact that this is ventricular tachycardia. And this is my last ECG. Thank you.
Sir,
Yeah.
there is a term that says that is a rabbit's left ear, rabbit's right ear. Can you explain it, sir, from the first ECG, sir?
Oh, rabbit is rabbit ear. Oh, so basically, I mean, what we are looking at in typical right bundle branch block, you will see the first R will be smaller than the second R. This is reversed. The first R is bigger than the second R. This is the first ECG, and this is true again for the other ECG also. So this is reverse pattern. I call it rabbit ear because it looks like two with a kaner moto dekha jay, rabbit ear.
Yes, sir.
Yeah. But the point is right bundle left axis. Every time we see right bundle left axis, be careful. We have to consider ventricular tachycardia and with relatively narrow QRS complex. Thanks.
Thank you, sir. Sir, we probably we rest of the scheduled lectures, Professor Hafiz's lecture is not there, and there is no ECG of the week. Sir, is there any ECG of the week?
Yes, there was, but
Yes, sir,
is not available. Zaman আছে?
Oh, no, sir, uni nei, sir nei ajke.
Then we can present it next day. Orun Maski, do you have any ECG?
No. No ECG.
No?
All right.
Okay.
Sir,
Thank you.
Sir, just have a question, sir, if you don't
Yes.
mind.
Sure.
Sir, in that lady with RBB left axis deviation, can we thought of and the relatively narrow complex or relatively wide QRS, could you have tried verapamil thinking the fascicular VT?
Yes.
Is it possibility, sir?
We considered it. The problem was the blood pressure was around 90. And I told them not to give verapamil because if we have given verapamil and once the blood pressure drops, we would have no recourse to doing anything. So even though it was a relatively young patient, we felt that probably amiodarone would be the best choice at this time. And we felt pretty confident that this was VT. That was the reason. But if it were, the other problem was that by that time we got the echo also, the ejection fraction was low. So yes, this is a consideration if we have to.
ECG of the week ta dekhate paro.
Question, sir.
Yeah.
If you get a small persistent
দেখা দাও তোমার কাছে রেডি আছে
1 AVL56, but you do not get typical RBB pattern in V1. The QS complex is less than around 110, not 120 millisecond. So can we call it incomplete RBBP?
Well, incomplete right bundle definition is anything over 100 millisecond.
Yeah.
100 to 120 milliseconds.
The typical RBB pattern is not there in V1, but the persistence in lateral lead is present.
I will not call it because, by definition, we have to fulfill those together. But even though we can say there is right-sided conduction delay, but it gets confusing. If we don't have that M pattern in lead V1, it's tough to call. And we see a lot of those ECGs, like you will see ECGs with not much of any pattern in V1, but in V6, there is terminal deep S wave. These are right-sided, definitely right-sided conduction delay, not fulfilling the criteria for bundle branch block.
So can I show ECG?
Yeah, please.
Sorry, this is not. So, this is an ECG of a female, 50 years old. He has a complaint of chest pain for 3 days and shortness of breath on exhaustion for 1 day. I got this ECG while this patient came to me for an echo with this complaint. So I will tell later what is the echo finding, but what is this ECG?
What was your diagnosis?
Sir, I think it is a atrial fibrillation ECG, but the P waves are a little bit coarse with incomplete RBB with normal axis. But I have some queries also because I can see some ST depression in the anterior leads with tall peak T wave. So what is the explanation of this kind of?
Wadud.
Sir, it is very interesting is that in AVL you get a completely negative complex, but in lead 1 it's not. There is a persistent S wave, but not negative complex. Again, in the limb leads, the highest QS complex in lead 3. So the axis is towards a little bit towards the right.
Yeah.
And there is incomplete RPB, it is there. And the T wave, it looks a little too much peaking in there. So I would always ask in this patient, what is the creatine level and what is the potassium level? And the T wave depression, ST segment depression is present in V3 to V6, V2 to V6 actually. I would pay attention to it. I would call it anterior ischemia.
Actually, that's what I want to say because this patient, I've got the finding, this is a patient of atrial septal defect. Septum defect is about 22 millimeter. But this patient symptom was he has got chest pain for 3 days, not that much, no acute symptoms, and exhaustional shortness of breath for 1 day. So I requested that patient to get admit, but she's not agreed. That's why I can't collect further data. So, but I feel this is a very interesting ECG because these two waves are, and another thing, this patient has no kidney issue. So creatinine was normal. I asked her, he called no, that was fine. He checked recently.
Another thing is that look at the ST T wave junction. It's very sharp.
Yeah,
Sharp
shouldering. It's like shouldering.
Ischemia. because it should be easily mounted up. It's not like that. This
What are the echo find? Was there any shunting from right to left or left to right?
Sir, shunt was left to right.
Okay.
There's no shunt reversal.
What was the LV size? Because the R wave in the P5, V6 is looking like LVH.
No,
Was there
there
a-
was no LVH, sir. So after seeing this ECG, I tried to see if there was no LVH. Just
the
there was
calculation-
pulmonary
calculation-
hypertension is there, and
the
PSP was 56.
Dr. Habiba?
Yes,
If
sir.
the calibration is in 20 square?
Yes, the standardization is double, Firoze.
Yes, sir.
Yes, standardization is double G, sir.
So then the ST segment depression is negated.
Yes, that calibration
State.
changes the ST segment. That's the minimal.
Very accurate, insightful observation.
Thank you, Habiba. Firoze.
Thank you, sir.
Sir, one more ECG. We need comment from Rafique, sir. Just one more ECG, sir.
Sure.
Hey,
You guys
Firoze,
are sharing the screen. Okay.
hey, Khalik Zaman is here. Khalik Zaman.
Yes, sir.
ECG, please.
Okay, I'm showing it.
This is এটা বড় করে দাও।
দিচ্ছি স্যার।
Khalik Zaman.
Yes, sir.
Yes, sir.
Yes, you just.
You can tell the brief history of the patient. And
he's around 30 years old male. He has got scholarship for studying on computer science in USA. And for screening purpose, before going to the USA, he was subjected to do some certain investigation, including an resting 12-lead electrocardiogram. That reveals that picture. And the report, the cardiologist reported it as atrial fibrillation. So he was in tension. So another doctor referred the patient to me for evaluation and further management if it is necessary. But on history and query, I did not find anything positive finding. There is no history of exertional dyspnea. There is no history of chest pain. There is no history of sleep apnea-like syndromes, that is snoring at night and apneic attack. And there is no history of even palpitation even. He does not complain of any exertional dyspnea even. On clinical examination, he was completely okay, including his blood pressure, heart sounds, and there is no added sound in the precordia. Echocardiography reveals there is no atrial abnormalities, there is no ventricular abnormalities, there is no right-sided pressure overload, no congenital or acquired valvular or any cardiac problem, and the ejection fraction was normal. So now, what is the ECG diagnosis of this patient, and what should be the further way of evaluation of this patient?
Wadud bhai, then sir.
না এটা খালিকুজ্জামান বলুক না, ওর ইন্টারপ্রিটেশন সুন্দর করছে তো।
তার আগে স্যার
খালিকুজ্জামান তোমার ইন্টারপ্রিটেশনটা দেখা।
Next slide. Ripu.
Next slide.
ইন্টারপ্রিটেশনটা দেখাও।
Ripu, next slide.
স্যার ফিরোজ স্যার দেখাচ্ছেন স্যার এটা।
ফিরোজ।
ওই যে স্যার এসেছেন।
আচ্ছা নেক্সট স্লাইডটা দেখো।
হ্যাঁ।
এই যে এটা দেখো, হ্যাঁ।
The rate was around 90 beats per minute, and there is irregularity in the rhythm. And there is P waves. The identity or the morphology of the P wave differs in single lead around 3 or more than around 3 morphologic type of the P wave.
এটা আগের ইয়েটা দেখাও আগে তুমি এটা
And there is, sir, এটা
আগের স্লাইডটা
না এইটাই মার্কার দিছে
পরের স্লাইড ওই মার্কার দেওয়াটা দেখো ইয়েস
এটা বড় করে দেখাও না একটু
এখন তো বড় করা যাবে না স্যার
আচ্ছা ঠিক আছে এরপরে এখন আবার শুনে যাও
you can hardly see any distinct very classical P wave in the ECG leads. So it appears that it a case of multifocal atrial rhythm as the rate was 90 beats per minute. But at the same time, we are thinking about other possibilities like whether it is a wandering pacemaker or not. And ECG, you see the anterior chest lead in V1 and V2, there is appears to be a right ventricular predominance. But the echocardiography did not reveal any forms of right ventricular abnormalities.
Can you go back to the next ECG, please? Next slide. Yeah, I think this is a superb evaluation of this ECG. I mean, for the younger doctors, if you look at this ECG, it looks so confusing. And if you go back to the 12 lead 1, 2, 3, you cannot say which one is the sinus rhythm. But if you look in the bottom, clearly the first red marking is sinus. Why? If you go up in lead V1, you see the biphasic P wave. So there is no confusion that that beat is sinus beat. And if you follow that, then the other one that is marked is also a sinus beat. And then, of course, we have this multiple different morphologies of P wave. So the diagnosis is exactly what you have analyzed it as. And the question would be what to do with this patient. Patient is asymptomatic, so we don't have to do anything, but I'm sure for a young person, this is an unusual rhythm, and it should be followed clinically in future and how he's doing. Thank you. This is a good, excellent interpretation of this ECG. I mean, you did not take this ECG, you just did not. This shows that a meticulous reading of an ECG. That means you did not make a cursory look and just, oh, this is atrial fibrillation because the RR is irregular. Or, oh, this is nothing. Or this is sinus rhythm. No, that was not the analysis of this. Please remember, all the younger doctors, this is how an ECG should be read. Thank you.
Firoze, as a last slide to final.
Explanation সবাই দেখো
আরেকবার দেখো
explanation হ্যাঁ Khaliquজ্জামান, was the patient a smoker?
No, sir. He was not a smoker.
Very interesting.
Very interesting, sir.
I mean, we have young patients with atrial tachycardia. But the part that doesn't add up is some of the ectopic beats are coming at a longer coupling interval. So there must be some problem with the sinus node itself also. Otherwise, normally you will see ectopic atrial tachycardia once the rate gets faster than the sinus rate. But this is not the case with this patient.
Thank you, sir.
Thank you. Thank you. I can stop sharing this one. I think we are at the end of our session. May I request Professor Atahar Ali sir to wrap up the session. And definitely thank you, Dr. Monwar. He's not with us at the moment, and Dr. Umme, Habiba, Ferdaushi for brilliant presentation. And Professor Atahar Ali sir, please.
Actually, I'm happy to thank everybody for being with us for more than 2 hours, and it was really, we are happy to see excellent presentation from Dr. Monwarul Islam. It was a elegant presentation, and finally Dr. Habiba Ferdaushi also. That was an excellent. Actually, unless we see the cases, we cannot expect what kind of presentation it can be. And it is Khaliquজ্জামান also presented an excellent ECG last of all. And finally, we are always feel proud to have every day we enjoy Rafique sir's lectures, and I think our younger, that is our participants, always send some messages and request us to see such type of ECG, sir. That is this is the simple ECG and the more discussion about this ECG. So finally, thanks to Dr. Monwar, he is not here, Dr. Ferdaushi, Dr. Zaman, and we are sorry that we still last Saturday we missed Dr. Hafiz Bhai's presentation, and this today also, and we hope to hear his presentation next Saturday. And I want to thank, and it is Wadud Bhai who will wrap up the session.
Natar Bhai, that's enough. We have really enjoyed it, and these interactive sessions are actually teaching us each and every day something new, and just refreshing our memories again and again. And thanks to Rafique sir, I think we are accustomed to thinking logically and describing and interpreting an ECG systematically. That's what we are learning actually. And thanks to him, that even the faculties are becoming accustomed to that. And today's the example is the beautiful interpretation by Dr. Zaman. Apparently confusing ECG, beautiful, simple explanation, wonderful understanding. Thank you. Thank you, everybody.
Thank you, sir. Thank you, everybody.
Thank you. Thank you all.
Atahar sir, is there any announcement for next session?
Yes, next Saturday also our case-based presentation, and in that day our Govindo is the presenter, and possibly Aisha Kadir may be another presenter. That is the next Saturday, and Dr. Hafiz and Rafique sir is always with us. That is next Saturday.
Thank you. I think we can conclude the session. Thank you, everybody, for being with us.
Thank you all.
Thank you, sir.
Assalamu alaikum.
Hafiz bhai, yes, we can see Hafiz bhai. Last of all.
কিছু শোনা যাচ্ছে না।
Still cannot hear.
But
he is muted.
Yes. Rafique sir মিস করছেন। হাফিজ ভাই না আজকে Rafique sir ভালো লাগে না।
He is muted actually. Yeah.
হাফিজ স্যারের মনে হয় সাউন্ড সিস্টেম
আর থাকতে পারছি না। আসসালামু আলাইকুম, ক্ষুধা লাগছে।
খুদা হাফেজ এভরিবডি।
আল্লাহ হাফেজ।
আল্লাহ হাফেজ।
Thank you, sir. Assalamu alaikum.
Thank you, Ribu.
Habiba, we want to see you every day.
Thank you, sir. Of course, I will try. Thank you. Thank you
Thank
very
you,
much,
Ribu.
sir.
Thank you. Thank you.
Thank you, sir.
Thank you, Zaman.